Hello everyone. So today we are going to discuss about pancytopenias. So pancytopenias are basically they can be encompassed into bone marrow failure syndromes um, and acquired syndromes. So it's basically inherited and acquired. So today I'm going to discuss about inherited bone marrow failure syndromes, acquired pancytopenia, the severe aplastic anemia, and the modalities are. I think that most of them would be coming across during your clinical practice, but inherited is something that is a bit of there's a bit of rarity in this disease spectrum. So we will just discuss in a nutshell about inherited bone marrow pancytopenias in this particular class. So here, as you can see, pancytopenias refers to the reduction below normal values of all three peripheral blood lineages, leukocytes, platelets, and erythrocytes. So lymphocytes are spared as they are not marrow dependent, have extra marrow sites of production like thymus and spleen. But having said that, when we look at the counts and peripheral smear, you particularly see there is a decrease in all the three cell lines. So here you can see that what is the exact definition? If HB is less than 10 gram per deciliter or absolute reticulocyte count is less than 40,000 per microliter, total neutrophil count of less than 4,000 per microliter, or absolute neutrophil count of less than 1,500 per microliter, platelet count of less than 1,50,000 per microliter. These are the definitions of pancytopenia. So it need not be that every time it is exactly this way. Sometimes even if sometimes we look at the MCV also. MCV is high. There is always a confusion between vitamin B12 deficiency and severe aplastic anemia. So we need to know all of these things also to have a close view about when to diagnose it as pancytopenia. So the causes of pancytopenia, sometimes it could be hypocellular, sometimes it could be cellular, sometimes there could be infiltration. So coming to hypocellular entity, if there is inherited marrow failure syndromes, acquired pancytopenias, hypoplastic variant of myelodysplastic syndrome. This is hypocellularity. Cellular is primary bone marrow diseases like acute leukemias, secondary to systemic diseases like SLE, B12 or folate deficiency, storage diseases, Gaucher's Niemann-Pick's, myelodysplastic syndrome. Infiltration is metastatic tumors, myelofibrosis, hemophagocytic lymphohistiocytosis, and osteopetrosis. So here you can see the pictures which show there is a cellular marrow, lot of fatty spaces in that cellular marrow where there is the cells are there with a lot of this thing, and infiltration. You can see a lot of blasts and hemophagocytes in the other slides. But essentially in a aplastic anemia picture, it is mostly fatty space. The marrow spaces are fat infiltrated. Fatty spaces are there. So that is one way of how to, look at the marrow aspirate and biopsy slides and make a diagnosis. Coming to causes of pancytopenia. Coming to causes of pancytopenia, there is inherited and acquired. Coming to inherited disorders, so I'm going to discuss about inherited disorders in this particular class. So that is Fanconi's anemia, Squamon-Diamond syndrome, dyskeratosis congenita, congenital amegakaryocytic thrombocytopenia, reticular dysgenesis, unclassified inherited bone marrow failure syndromes. So then we have other genetic syndromes: Down syndrome, Dubovich syndrome, Seckel syndrome, Schimke immunoosseous dysplasia, cartilage hair hypoplasia, Noonan syndrome. So there are also some other things like autosomal recessive, chromosomes affected. So So inherited pancytopenic syndromes, these are the syndromes. Having said that, Down syndrome, Dubovitz, Seckel syndrome, these are all, they don't only have pancytopenia, they have other symptoms and signs and all of those things. Along with that, they have a pancytopenic picture. So I just wanted to just hold this slide so that you have a memory of all of these disorders. So I'll just briefly discuss about everything. Fanconi's anemia is an autosomal recessive spectrum where chromosomes affected are 16, 9, 33, 6, and 11. Gene mutation is FANK to G. Normal age at diagnosis is 3 to 14 years. Incidence is 1 in 1,60,000 individuals worldwide. So coming to pathology, DNA damage. So once there is DNA damage in the Fanconi's anemic children, the Fanconi's anemia complex, you can see that the FANC D2 is then, so what happens is there is a mutation in the FANC A, B, D genes, and because of that, there is the DNA repair mechanism is not functioning properly. So any kind of triggers like radiations, like environmental triggers or genetic triggers, or any coexisting mutations like monosomy, chromosomal aberrations like monosomy 7, inversion 16, 19, or any, post leukemic pictures like, in AML, ALL. In these conditions, with coexisting Fanconi's anemia, there are a spectrum of symptoms and signs that can be seen. And out of that, pancytopenia is also one hematological picture which could be treated, when diagnosed at the right time and in the right in a timely fashion, is with bone marrow transplant. So, and also recently gene therapy has also come into picture only to treat Fanconi's anemia, but it's not really still being followed in India. So coming to clinical manifestations, you can see that hyperpigmentation of trunk and neck, cafe au lait spots, short stature, absence of radii and thumbs, maybe hypoplatic bifid or absent, anomalies of feet, congenital hip dislocation, genitourinary, underdeveloped penis, undescended atrophic or absent testis, hypospadias or phimosis. Females, malformations of ovaries, uterus, and vagina. Fanconi's anemia facies, microcephaly, small eyes, epicanthal folds, and abnormal ears. Ectopic pelvic or horseshoe kidneys, 10% may show cognitive delays. Lab findings. In this complete blood picture, thrombocytopenia and RBC macrocytosis, initially followed by granulocytopenia and then anemia. Marrow aspiration is hypocellular and fatty, like I discussed before. And chromosomal fragility, what we do is chromosomal fragility test, diapoxybutane and mitomycin C. And also we look at recently we have the NGS, which can pick up all of these FANK-B mutations. Complications, they are more prone for cancers. Squamous cell carcinomas of the head, neck, and upper esophagus, followed by vulva, anus, cervix, and lower esophagus. HPV may be the cause. Androgen therapy, liver tumors, adenomas, hepatomas, pileosis, hepatis, blood-filled hepatic sinusoids, all of them complications. Clonal marrow cytogenic abnormalities can lead to MDS and acute myelogenous leukemias. Prognosis, median survival is more than 30 years. HCT have improved the prognosis, and surveillance for complications like cancer and prompt intervention has improved survival. Common diamond syndrome is an autosomal dominant entity, and chromosomes affected are 7q11, and gene mutations are SBDS. The gene protein is involved in the ribosomal biogenesis. Pancreatic insufficiency is a result of failure of pancreatic SNR development. Bone marrow failure is characterized by dysfunctional hematopoietic stem cells. So clinical manifestations are pancreatic insufficiency, there is fat malabsorption that improves with age. Clinical features of anemia, neutropenia, or thrombocytopenia. Bacterial or fungal infection secondary to neutropenia. Short stature, skeletal abnormalities, delayed bone maturation, metaphyseal dysplasia, short or flared ribs and thoracic dystrophy, hepatomegaly, dental abnormalities and poor oral health, neurocognitive and social problems. Lab findings include neutropenia if it is 100%, anemia 66, thrombocytopenia 60, pancytopenia 44%. Marrow hypoplasia and fat infiltration, fat malabsorption 72 hours stool assay, pancreatic function test, age-adjusted serum trypsinogen and isoamylase levels are reduced. Mutational analysis for SBDS gene. Complications are predisposed more to MDS and leukemic transformation. The median survival is 35 years. There is 50% spontaneous conversion to pancreatic sufficiency. HSCT for severe cases has improved survival rate. Coming to dyskeratosis congenita, there is X-linked, it is X-linked or autosomal recessive. Chromosomes affected are XQ28, 3Q26. Gene mutation is DKC1 and TRC, characterized by mucocutaneous abnormalities, bone marrow failure, and a predisposition to cancer and MDS. Skin manifestations are most common in the first decade of life, and aplastic anemia is most common in the second decade of life. So this is mostly an X-linked and autosomal recessive entity. So the pathology includes if there are mutations in genes that encode components of telomerase complex, T-loop disassembly, protein, telomerase capping, which required for telomerase maintenance. X-linked recessive is XQ28 DKC1 gene. Autosomal dominant TINF2 or TRC or TRT. Autosomal recessive is NOP10, NHP2, RTEL1, TCAB1, and CTC1. There is impaired telomere maintenance, which leads to short telomeres, which are cardinal markers for dyskeratosis congenita and for marrow failure. Marrow failure is due to progressive attrition and depletion of hematopoietic stem cells because of premature senescence. Clinical manifestation, the mucocutaneous triad, reticulate skin, pigmentation of upper body, mucosal leukoplakia, and nail dystrophy. Skin pigmentation and nail changes first to appear. Mucosal leukoplakia and excessive ocular tearing later, and by mid-teen there is marrow failure. So for all these inherited bone marrow failure syndromes, even though they don't present with marrow failure at the beginning, by adolescence or post that, by default they develop marrow failure, and bone marrow transplant would be warranted at that time. And sometimes during this course, if there are some other mutations. Also, so there should be a regular surveillance happening for these kids with regular bone marrow aspirates, biopsies, and yearly checks. So here I've just put all the clinical manifestations: skin pigmentations, nail dystrophy, both hands and feet, leukoplakia of oral mucosa, hyperhidrosis of palms and soles, hair loss, excessive tearing, conjunctivitis, blepharitis, loss of eyelashes, strabismus, cataracts, and optic atrophy, dental decay and early loss of teeth, osteoporosis, avascular necrosis, genitourinary hypoplastic testes, hypospias, phimosis, urethral stenosis, and horseshoe kidney, esophageal strictures, GI bleeds, hepatomegaly, and pulmonary restrictive defects. These are the pictures for that. Lab findings, in the CBP, there is initial thrombocytopenia, anemia, or both followed by pancytopenia, macrocytic RBC and elevated fetal hemoglobin, marrow hypocellular. Some patients may have decreased B lymphocytes or T lymphocytic count, and telomeres are short. Complications, cancers of the skin and GIT, esophagus, stomach, colon, anorectal sites may develop by 3rd to 4th decades, squamous cell carcinomas of head and neck, tongue, mouth, pharynx. They're predisposed to MDS, pulmonary fibrosis, and severe GI bleeding. Prognosis, TERC, TERT have better prognosis than DKC1, TINF2, and RTEL1. Mean survival age is 30 years and cause of death is marrow failure, complication of HSCT, cancers, fatal pulmonary problems, and GIBs. Next up is congenital amylocariocytic thrombocytopenia. It is the rarest of the 4 inherited pancytopenias. It is an autosomal recessive entity. The chromosomes affected are 1p34. Gene mutation involved is MPL. It manifests in infancy as isolated thrombocytopenia. Later, pancytopenia occurs in the first few years of life. Pathology, there is mutation in the MPL gene, which codes for the receptor of thrombopoietin, which is the growth factor that promotes hematopoietic stem cell survival, megakaryocyte proliferation, and maturation. Non-sense mutations cause complete loss of function of thrombopoietin receptor, leading to low platelet counts, fast progressing to pancytopenia. Missense mutations are milder forms associated with a transient increase of platelets during the first year of life and slow progression to pancytopenia, if any. Clinical manifestations include petechial rash, bruising, or bleeding at birth or in the first year of life. Neurological include cerebellar or cerebral atrophy and developmental delay. Cardiac includes congenital heart disease, ASD, VSD, PDA, TOF, and coarctation of aorta. Abnormal hips or feet, kidney malformations, cleft or high arch palate, and microcephaly. Lab findings include thrombocytopenia with normal hemoglobin levels and WBC count initially. Later, pancytopenias. Macrocytic RBCs, elevated fetal hemoglobin. Marrow, normal cellularity with marked reduction or absence of megakaryocytes. Complications can lead to MDS and acute leukemias. Prognosis, mortality is almost 100% in nonsense mutations due to bleeding or pancytopenia or leukemic transformation. Missense mutations may have milder course with serious complications. So these are all inherited bone marrow failure syndromes. Next, we have other inherited syndromes like Down syndrome. So Down syndrome, in addition to predisposition to ALL and AML, like I discussed before, Down syndrome patients can show pancytopenia. It need not be a leukemic transformation, but there could be an hypocellular marrow or an aplastic kind of picture. And so we need to do regular checks, at least of the CBCs, to look at the counts. Next is Dubovitz syndrome. Dubovitz syndrome, it is an autosomal recessive disorder. So they have peculiar faces, infantile eczema, small stature, and mild microcephaly. Face is small with shallow supraorbital ridge, a nasal bridge at the same level as forehead, short palpebral fissures, variable ptosis, and micrognathia. The patients may have pancytopenia. So this is a picture of how a Dubovitz child looks like. Sickle syndrome, also called bird-headed dwarfism, autosomal recessive, marked growth failure and mental deficiency, microcephaly, a hypoplastic face, and a prominent nose and low set of malformed ears. This is how a sickle syndrome child looks like. Next is reticular dysgenesis, that's an immunological deficiency syndrome with congenital agranulocytosis, autosomal recessive 1p35 X-linked in some cases. Noonan syndrome is a developmental disorder. In Noonan faces, hypertelorism, ptosis, short neck, low set ears, short stature, congenital heart disease, and multiple skeletal and hematological abnormalities are seen. So there is it's an autosomal dominant disorder, and mutations are seen in PTPN11. So Noonan syndrome is also coexisting with a condition called JMML. It's a kind of leukemia which has these PTPN11 mutations. So when a child with JMML walks in, we should also think of Noonan syndrome and keep and also do a chromosomal test for that. This is how a Noonan syndrome child looks like. So apart from all these inherited bone marrow failure syndromes, the other cause of pancytopenia is HLH, that hemophagocytic histiocytosis. So HLH, I think most of you must be knowing in the clinical practice during infections, during viral infections, bacterial infections. Is a secondary HLH is quite common in all of these conditions with prolonged course of the disease. So also there is a spectrum of primary HLH and also there is a spectrum of histiocytic disorders with like Rosai-Dorfman syndrome, Erdem-Chester disease, So all of these histiocytic disorders, and so I'm just touching upon hemophagocytic lymphohistiocytosis here. So there is a disease. It's a disease of severe hyperinflammation caused by uncontrolled proliferation of activated lymphocytes and macrophages. Its primary form is autosomal recessive. A secondary form can be triggered by infections, immunodeficiency, or underlying malignancy. It is overwhelming activation of normal T lymphocytes and macrophages, invariably leading to clinical and hematological alterations and death in the absence of treatment. Unclassified inherited bone marrow failure syndromes. There are heterogeneous disorders that can be either atypical presentation of identifiable diseases or new syndromes, characterized by various cytopenias because of underproductive bone marrow with or without physical manifestations, but they do not fit in the classic bone marrow failure disease. Criteria includes does not fulfill criteria for any categorized inherited bone marrow failure syndrome, fulfills at least two of the following: chronic cytopenia detected on at least two occasions over at least 3 months, reduced marrow progenitors or reduced clonogenic potential of progenitor cells, or evidence of ineffective hematopoiesis, high fetal hemoglobin for age, red blood cell macrocytosis, fulfills at least one of the following: family history of bone marrow failure, presentation at age less than 1 year, anomalies involving multiple systems, suggest an inherited syndrome. Acquired pancytopenia, drugs, dose-related antimetabolites, methotrexate, mitotic inhibitors like daunorubicin, alkylating agents like busulfan, nitrosourea, anthracyclines, idiosyncratic chloramphenicol, chlorpromazine, gold salts. Toxic chemicals like benzene, infections, viral hepatitis B and C, EB virus, HIV, autoimmune like SLE. Myelodysplastic syndromes, PNH, hematological malignancies like leukemias, lymphomas, myelomas, metastatic tumors of the bone, deficiencies, hypersplenism, storage diseases, osteopetrosis, and myelofibrosis. So, acquired pancytopenia, these are the causes. Drugs, again, toxic chemicals, infections, autoimmune. So, these are the acquired. So, here what happens is in acquired spectrum, pretty much the pathogenesis is kind of same. Finally, the trigger is one thing, but the final pathology essentially is kind of common to all of these acquired conditions. So if there is a direct cytotoxic effect on hematopoietic stem cells from drug chemicals, cell-mediated or antibody-dependent. It can be either a cell-mediated response or an antibody dependent response. It's a direct cytotoxic effect, and it's immune mediated with increased circulating T lymphocytes producing cytokines that suppress hematopoiesis. So myelodysplastic syndromes, also known as pre-leukemic syndromes or dysbiotic syndromes, heterogeneous group of leukemia related conditions having abnormal development in marrow elements, have a more chronic course than leukemias. 5 groups include refractory anemia with ringed sideroblasts, refractory anemia with excess blasts, chronic myelomonocytic leukemia, refractory anemia with excess of blasts in transformation. PNH is a rare acquired disorder of red cell membrane where there is intravascular hemolysis due to sensitivity of RBCs to complement and defecting membrane. Gene is glycosyl phosphatidyl inositol. Protein defects are decay accelerating factor DAF, membrane inhibitor or reactive lysis MIRL. Hematological malignancies are leukemia. Some cases show pancytopenia with blast cells. Advanced stages of NHL may show pancytopenias. Multiple myeloma, marrow failure leads to pancytopenia. Metastatic tumors of the bone. Bone is the third most common location for metastasis after the lung and the liver. Many cancers can spread to the bone. The most common are prostate, lung, and breast. They can suppress marrow and lead to pancytopenia. Deficiencies include folate and B12 deficiency, a classic cause of megaloblastic anemia, like I discussed before. MCV is quite high in these conditions, so we need to have a close understanding of when it is B12 and when it is aplastic anemia. And although these deficiencies commonly present with anemia and thrombocytopenia, they can occasionally present with pancytopenia due to excessive apoptosis of hematopoietic progenitor cells. Like I discussed before, there is a direct cytotoxic effect, either cell-mediated or antibody-mediated. Anorexia nervosa has also been reported to lead to bone marrow failure, most likely through severe vitamin and mineral deficiency. Coming to hypersplenism, hypersplenism is an enlargement of the spleen, splenomegaly, with reductions in one or more blood cell lines. It is fairly common cause of pancytopenia. There are many different diseases that cause splenomegaly, and these diseases can be grouped under the following headings: hematological, portal hypertension, glycogen storage diseases, systemic diseases, infections, or tropical. Pathophysiology: pancytopenia can be caused through sequestration of large amounts of blood cells in the spleen, with phagocytosis of these blood cells by the spleen's resistant macrophages. Diagnosis is made through full blood count confirming reductions in the cell lines, increased reticulocytes due to increased marrow output, and palpation revealing an enlarged spleen. The standard treatment for hypersplenism is treatment of the underlying cause. A splenectomy may be necessary. Storage diseases: Gaucher's disease, autosomal recessive disorder, deficiency of lysosomal enzyme, glucocerebrosidase, which cleaves group from ceramide. This defect results in lysosomal accumulation of glucocerebroside in phagocytic cells of the body. Large macrophages called Gaucher's cells can be seen in bone marrow, leading to pancytopenia with marrow failure. Niemann-Pick disease, autosomal recessive disorder, accumulation of sphingomyelin and cholesterol due to deficiency of sphingomyelinase. Macrophages in bone marrow leads to marrow suppression, leading to pancytopenia. This is the picture. You can see the Niemann-Pick. Osteopetrosis, also called marble bone disease, which is an autosomal dominant or a recessive disorder. Defect is in the osteoclast function of the bone resorption with continuous bone formation, which ultimately occupies the marrow space. Then there is myelofibrosis. It's an unknown origin. The proliferation of neoplastic stem cells at the multiple outside the marrow, like liver and spleen, because there is fibrous myeloid bone marrow. The other sides, which like the liver and spleen, become active and they start producing the stem cells. Then there is secondary myelofibrosis, can occur due to primary marrow disorders or due to toxins. Clinical features: anemia, pallor, easy fatigability, tiredness, headache, breathlessness, neutropenia, fever, sepsis, thrombocytopenia, that is petechiae, purpura, ecchymosis, mucosal bleeds like epistaxis, GI bleed, hematuria, features of underlying disease. Lab test: a CBC will show the severity of pancytopenia in terms of anemia, neutropenia, and thrombocytopenia. HB is less than 10 gram per deciliter or absolute reticular count of less than 40,000 per microliter. Total neutrophil count less than 4,000 per microliter or absolute neutrophil count less than 1,500 per microliter. Platelet count of less than 150,000 per microliter. Reticulocyte count of more than 3%. Corrected reticulocyte count of less than 1%. MCV is high. Peripheral smear, macrocytosis, neutropenia, and thrombocytopenia. Blast cells in leukemias. Bone marrow aspiration, acellular, hypocellular, or infiltrates. Coming to management, supportive care, transfusions like packed red blood cells. Aim is to keep the HB more than 9 gram %. 5 ml per kg increases HB by 1%. Platelet transfusion indicated in active mucosal bleeds, indicated in non-bleeding patients. Count is less than 500 to 10,000 per cubic mm in non-sick child, and count is less than 20,000 per cubic mm in sick child, wherein platelet count can fall fast, like in DIC infection before procedures like lumbar puncture. Less than 30,000 per cubic mm, surgeries less than 50,000. Dose of 4 units per meter square body area. Antimicrobials used in cases of suspected sepsis, used prophylactically in the post-transplant period. Broad spectrum antibiotics like third generation cephalosporins like ceftriaxone plus aminoglycoside, like amikacin, piperacillin, tazobactam plus amikacin. Vancomycin in case of MRSA. Antifungals to be started after culture growth indicates. Specific therapy includes androgens, granulocyte colony stimulation factor, immunosuppressive therapy, and hematopoietic stem cell transplantation. So here you can see androgens is one line of management to treat. They produce a response in inherited pancytopenias. They cause reticulocytosis and a rise in hemoglobin in 1 to 2 months. So white blood counts may also arise next, followed by the platelet counts. Once the response plateaus, the dose can be tapered but not stopped entirely. So nandrolone enthatate is 2 to 5 mg per kg per day injectable form. Once in 10 days, continued till response is evident. Then there's low dose of 0.5 to 1 mg per kg per day. Prednisolone may be added to every second day to counter androgen-induced growth acceleration. Disease may become refractory as marrow failure progresses. Side effects include masculinization, elevated liver enzymes, cholestasis, pileocystitis, and liver tumors. So another way to increase is the granulocyte colony stimulating factor. It can be used to boost absolute neutrophil count, occasionally platelet counts, and hemoglobin levels. Combination therapy of GCSF given subcutaneous daily or every 2 days, along with erythropoietin given subcutaneous or IV 3 times a week. Immunosuppressive therapy, it consists of anti-thymocyte globulin, ATG, and cyclosporin. This is the option if stem cell transplant can't be done. Eligibility: rule out Fanconi's anemia, no use. Patient must be free from serious infections. Platelet count of more than 20,000 per cubic mm, and HP, ATG, anti-thymocyte globulin, ALG, lymphocyte globulin. Horse and rabbit ATG, ALG are available in India. Pre-medication with paracetamol, hydrocortisone, or dexamethasone to be given to avoid allergic reactions. ALG is 40 mg per kg per day for 5 to 10 days, and ATG is 15 mg per kg per day for 5 to 10 days. Serum sickness may develop by 10 to 14 days after ATG infusion, presenting as fever, rash, arthralgia, arthritis. Prevention: prednisolone in dose of 1 mg per kg per day, 3 divided doses, should be given along with infusion and continued for 2 weeks and then tapered over 1 week. Treatment: IV hydrocortisone or dexamethasone, then oral prednisolone. Cyclosporin, oral cyclosporin is 5 to 10 mg per kg per day in 2 divided doses, started on day 21 after stopping prednisolone to prevent hypertension. It is continued for 3 to 6 months for response. Side effects include hirsutism, gum hypertrophy, hypertension, liver dysfunction, renal toxicity. The response to IST should be continued for 3 to 6 months. IST should be continued for 3 to 6 months. Patient is assessed after 3 to 4 months and then periodically. Response is defined as hemoglobin levels normal for age, ANC more than 1500, platelets more than 1,50,000. If first course fails to give response, try for second course. Hematopoietic stem cell transplantation in young patients, that this is the ultimate curative option. So now the recent guidelines, the guidelines say that when there is severe aplastic anemia and you have a matched sibling donor, then the first line to treat is to do a hematopoietic stem cell transplantation. For if you don't find a matched donor, or you have a half match also. A half match and IST should be weighed, which one would be better for that particular child. If there is hypocellularity, if there is frank, there are a number of ways to decide which one is the better way. But the curative option for aplastic anemia is hematopoietic stem cell transplantation. It has 80 to 90% cure rates. Now it has also almost gone up to 95, 98. With few long-term complications. Needs HLA matched donor preferably, that's a matched sibling or a family. More risk of graft versus host disease in partial matched family donor or matched unrelated donor. So graft versus host disease is a risk factor if for any kind of unrelated or unmatched donors. But with the recent advent of recent protocols, recent strategies to manage bone marrow hematopoietic stem cell transplantation, there is, it can be tackled, and almost it is equal to a matched sibling donor transplant. So bone marrow peripheral blood stem cells are taken from the donor, and for peripheral stem cell, GCSF is given to donor for 4 to 5 days, and then subjected to apheresis to collect the stem cells. Non-myeloablative conditioning-based combinations of ATG, cyclophosphamide, and fludarabine. Engraftment occurs in 10 to 15 days. So these are all aseptic precautions, and you should use only rated blood products. Once engraftment is established and patient has no infection, follow up on OP basis for 3 to 6 months. Complications include graft versus host disease and graft rejection. Acute GVHD can occur up to 100 days post-transplantation and is characterized by skin rash, diarrhea, and liver disease with jaundice and fever. Treatment is immunosuppression with steroids and cyclosporin. chronic GVHD occurs after 100 days of characterized by scleroderma with skin rash, Zika, complex hepatic dysfunction. Management is immunosuppression. Immunization post-transplant revaccination with routine vaccines like polio, diphtheria, tetanus, pertussis, Hib, and pneumococcal vaccines at 1 year after transplant when the patient is off immunosuppression. Follow up, look for regression or reappearance of symptoms, signs of GVHD. If patient is on immunosuppression, monitor for complications like hypertension, renal toxicities, hyperglycemia, CBC, LFT, RFT periodically. Check bone marrow aspiration or biopsy every 6 to 12 months to look for relapse of disease or malignant transformation. So I hope pancytopenias, you could just, I have just encompassed all of it in these slides, just for a bird eye view of all of these diseases. But when each syndrome or when each there is an entity which present to you, be it inherited or acquired spectrum, I think there should be a close watch of how the disease is progressing, and you should always rule out the cause. If there is a primary cause, treat the primary cause for aplastic anemia. Like if at all there is HLH, if there is secondary HLH, you need to treat the primary thing. If there is leukemia, then you need to treat the leukemia to get the pancytopenia under control. So always the primary cause should be treated. But in inherited bone marrow failure syndromes, like I've discussed, there are a number of strategies of how you manage. And the bone marrow transplant is an option. Now, recently, gene therapy is also coming to picture. So I hope this helps. Thank you.